Welcome to the Radong Smart Review GU Cancer Series.
Glad to be here for this one because today we're looking at a disease site where the margin for error is just virtually non-existent.
Oh, absolutely. I mean, the difference between a total cure and really devastating, life-altering complication can literally come down to a few millimeters of prepubic fat, or even just, an outdated textbook rule about the urethra.
Exactly. It's high stakes.
It really is. So this is episode 31, Penile and Urethral Planning Workshop. And, when you are sitting alone at the planning workstation late at night, these are the cases that force you to rethink everything you know about standard radiation delivery.
Oh, completely.
Oh, yeah.
Because the anatomy is highly mobile, for one.
Right.
And the setup defies standard immobilization. Plus, the evidence base requires some pretty serious interpretation. A sloppy field design here it's catastrophic for the patient.
Which is why we're doing this deep dive into the source material today. We really need to get into the weeds on this.
Yeah, we are dissecting everything. Simulation, bolus mechanics, penile brachytherapy physics, the inguinal and pelvic nodal contouring logic using the InPACT framework.
And obviously the raw anatomical reality of urethral cancer planning.
Right. And to ground all this physics and biology in real-world clinic scenarios, we have two very specific anchors.
Let's hear them.
So case one is a 52-year-old uncircumcised man. He presents with a 2.5 centimeter squamous cell carcinoma, or SCC, of the glands. The MRI shows invasion of the corpus spongiosum, but crucially without corpus cavernosa involvement.
Okay, got it.
And clinically, his groins are node negative, so he is CN0, and he strongly desires organ preservation.
Which is a very common request.
Yeah.
And then case two shifts our anatomy entirely. We have a 58-year-old woman with a distal urethral SCC. She's staged as a T2, meaning the tumor has invaded the periurethral muscle.
Right, the muscle layer.
Yeah. Her MRI shows local extension into that muscle, but we do not see any vaginal wall invasion. And like our first patient, she is also seeking an organ-preserving treatment.
So we have two rare presentations here that demand, totally distinct physical and conceptual approaches.
Right. And the goal is to get you board ready, but more importantly, clinic ready. Because your dosimetrists and your physicists, they're going to be looking directly at you for answers on these setups.
Oh, they will. They definitely will. And, every single physical treatment parameter we set rests entirely on the bedrock of flawless staging.
Which is tricky here.
It is notoriously tricky. Penile and urethral staging is full of classic board traps.
Yeah.
You simply cannot generate a curative plan for disease you've misunderstood anatomically.
Exactly. So looking at case one, our 52-year-old gentleman, the T stage is dictated strictly by the microanatomy of the erectile tissue.
Right. So a T1 tumor invades the subepithelial connective tissue.
Yeah.
A T2 tumor invades the corpus spongiosum. And a T3 tumor breaches the tunica albuginea and invades the corpus cavernosum.
And T4 is?
T4 is when it invades adjacent structures beyond the penis, like the prostate or the pubic bone.
Right. Okay. I need to interrupt the staging walkthrough right here because I see a massive trap.
The urethral trap.
Yes, the urethral trap. The older editions of the staging manuals, and honestly, a lot of the older attendings on the wards, they teach a very specific rule of thumb. Doesn't urethral invasion automatically bump the tumor up to a T3?
I see that exact misconception trip up residents every single year. It's so common.
Because it used to be the rule, right?
It used to be, but it is an outdated teaching now, and using it will result in fundamentally flawed patient counseling. In the current staging scheme, a T2 and a T3 can both have urethral invasion.
Oh, wow. Okay.
The urethra itself is no longer the dividing line. To understand why, you have to picture the cross-sectional anatomy.
Right, the cylinders.
Exactly. The corpus spongiosum is the vascular tissue that immediately surrounds the urethra. The corpus cavernosa are the two larger, higher-pressure erectile cylinders sitting dorsally.
So they sit on top.
Right. So if a tumor originates on the glands and invades deep, it hits the spongiosum first. Because the spongiosum encases the urethra, the tumor can easily invade the urethral mucosa without ever touching the cavernosa.
Ah, I see.
Therefore, the dividing line is the erectile tissue compartment, specifically the tunica albuginea that separates the spongiosum from the cavernosa.
That makes total sense.
Right. So because the MRI for case one clearly shows the corpus cavernosa are pristine, he is definitively a T2. regardless of whether his urethra is involved.
Which is huge, because if you misinterpret that scan, you are suddenly counseling a patient on a T3 disease paradigm. You're preparing them for a much more aggressive surgical intervention when they actually have T2 disease, which completely alters the feasibility of organ preservation.
Exactly. You change their whole life trajectory based on a staging error.
Right. Okay, so we have the local anatomy defined. The next hurdle is the lymphatic network. And urethral and penile lymphatic drainage is biologically really complex, but there is a rigid cardinal rule that defines our initial targeting.
Yes, the golden rule.
And I've got a quick mnemonic for you. Write this mnemonic down. DGP, distal to the groin, proximal to the pelvis.
BGP. That is perfect. Let us look at the embryological and anatomical mechanism behind that mnemonic, because it's fascinating.
It really is. It goes all the way back to fetal development, right?
It does. The urogenital tract forms through this complex descent and separation of the cloaca. As these structures migrate during fetal development, they basically drag their blood supply and their lymphatic drainage pathways with them.
So they take their plumbing with them.
Exactly. So for distal or anterior disease like case 2, our female patient with the distal urethral tumor, or the glands tumor, case 1, the lymphatic capillaries, form a superficial network that flows outward.
Directly to the inguinal nodes.
Right, directly to the groin. That means the superficial inguinal nodes first, followed by the deep inguinal nodes located within the femoral triangle, and then from there it moves sequentially beneath the inguinal ligament into the pelvic nodes.
But the proximal structures have a completely different embryological origin. For proximal or posterior disease like, say, a tumor in the prostatic urethra or the membranous urethra in a male, or the proximal third of the urethra in a female, the lymphatic vessels never route through the groin.
Right, they bypass it completely.
Yeah, they follow the internal pudendal and internal iliac vessels straight back into the deep pelvis. So if you have a proximal lesion and you are radiating the groins, you are exposing the patient to the risk of lymphedema for absolutely zero oncologic benefit.
Which is a terrible trade-off.
Truly terrible.
Now, what complicates the textbook picture are the advanced bulbar or junctional lesions, the ones that sit precisely at the anatomical watershed.
Right in the middle.
Yeah. If a tumor is massive enough to straddle both the distal and proximal compartments, the lymphatic drainage becomes bidirectional.
So you have to treat both.
You are forced to cover both the inguinal and the pelvic basins. But the absolute baseline you must defend on your boards remains. Distal drains to the groin, proximal drains to the pelvis. And critically, for penile cancer, direct pelvic nodal spread without ipsilateral inguinal nodal involvement is exceptionally rare.
So it has to stop at the groin first.
Right. The cancer cells must traverse the inguinal relay station first.
Okay, so applying the DGP biology to case 1. He has a T2 SCC of the glands. The glands is the ultimate discal structure. His primary lymphatic risk is the inguinal basin.
Spot on.
So he is accurately staged as a CT2N0, and he is asking for organ preservation. How do we physically engineer a treatment that eradicates the primary tumor without necessitating an amputation?
Well, the very first step has absolutely nothing to do with radiation physics.
Oh, right, the circumcision.
Yes. Case 1 is uncircumcised. A surgical circumcision is an absolute prerequisite, and it must occur and fully heal well before he ever gets on our CT simulation table.
Wait, I want to drill down on this because the protocol says circumcision is mandatory first, but why? Like, is external beam radiation really that disproportionately damaging to the foreskin compared to the rest of the penile skin?
It's a great question. It's about the physical conformation of the tissue and the radiobiology of squamous epithelium.
Okay, walk us through it.
The foreskin is a highly vascularized, redundant double layer of thin skin that constantly folds in on itself. When you deliver definitive doses of megavoltage radiation, you are depleting the stem cells in the basal layer of the epidermis faster than they can repopulate.
Which causes the skin reaction.
Right. This leads to brisk erythema and eventually wet desquamation. If that happens on a flat surface, we manage it with topical creams. But when wet desquamation occurs inside the dark, moist, closed environment of the prepuce, it becomes a massive reservoir for bacterial and fungal superinfection.
Oh, that sounds awful.
It is. Furthermore, the acute radiation induces severe lymphatic edema. The foreskin swells massively and tightens down, creating a severe radiation-induced phimosis.
So they're trapped.
Exactly. The patient physically cannot retract the foreskin to clean the necrotic tumor or the desquamating skin underneath.
Which means the patient ends up in the emergency department with a severe localized infection, and then you are forced to put them on an extended treatment break.
Right. And we all know what happens during a treatment break.
The surviving clonogenic tumor cells undergo accelerated repopulation, and you lose oncologic control, all because you tried to spare the prepuce.
It is a non-negotiable step.
Okay, so once he is healed from the circumcision, we move to simulation. And this is where it gets really tricky, because we need to create a setup that completely immobilizes a very mobile appendage while ensuring we don't underdose the surface. It's basically like casting a broken bone in a moving vehicle.
That is the perfect analogy. Casting a broken bone in a moving vehicle, the physical setup is notoriously difficult.
So how do we do it?
First, the patient is positioned supine. If we are treating the bilateral groins, we utilize a frog leg position.
Why frog legs specifically?
By externally rotating and abducting the hips, we stretch the inguinal skin folds flat. This prevents skin-on-skin maceration in the groin creases when the radiation dermatitis inevitably peaks.
That's a great clinical pearl.
Next, inserting a Foley catheter prior to the CT scan is highly recommended. It serves two purposes, really. First, it acts as an internal radiopaque marker, allowing you to trace the exact trajectory of the urethra on your planning CT.
Which is super helpful for avoiding strictures later.
Exactly. And second, the physical rigidity of the catheter provides an internal anchor that slightly improves daily reproducibility.
Okay, so position is set. Now we have to address the dose buildup problem. Because if you think of a megavoltage linear accelerator beam like a powerful flashlight shining through a thick pane of glass, the maximum heat or the maximum dose deposition doesn't happen on the immediate surface of the glass.
Right, because of the high energy.
Right. Because of the high energy of the photons, they have to travel a certain distance into the tissue, knocking loose secondary electrons before the dose peaks.
Yeah.
And this is the buildup region. For a standard 6 megavolt beam, that peak dose, or Dmax, is about 1.5 centimeters deep. If you aim that beam at a penile skin cancer in free air, the maximum dose will land deep inside the cavernosa, and the actual squamous cell carcinoma on the skin surface will be drastically underdosed.
So we have to trick the beam into building up its energy early.
Exactly. We have to pull it forward.
And to pull that Dmax onto the skin surface, we must surround the target with bolus, a synthetic tissue equivalent material. You have several options, but they all carry distinct physical challenges.
What are the main options?
Well, you can create a custom wax mold that encases the penis. You can use a malleable water equivalent plastic, or you can use a water bath setup.
The water bath is interesting.
Yeah, in a water bath technique, the patient is simulated and treated with the organ submerged in a custom-built water-filled cylinder. Water is perfectly tissue equivalent, meaning it provides seamless bolus without any microscopic air gaps that might perturb the dose.
But practically speaking, the water bath technique is incredibly cumbersome for the therapists. I mean, think about setting up a perfectly leveled water cylinder every single day, managing the displacement, ensuring the water temperature is tolerable, and preventing spills on the treatment couch. It introduces massive opportunities for daily setup error.
It really does.
And if the setup isn't reproducible, your beautifully designed decimetric plan is worthless. Now, if you use external beam for comprehensive pelvic and inguinal fields, you might skip the bolus and simply use suprapubic fixation, literally taping or securing the penis to the lower abdomen.
Which is much simpler.
Yes. But whatever technique you choose, the right answer is always the one your specific physics and therapy team can flawlessly execute 35 days in a row.
That is the truth. So let us evaluate the specific treatment modality for case 1.
Yeah.
We have our options: external beam radiation therapy versus brachytherapy. For a highly selected patient like case 1, where the lesion is under 4 centimeters, strictly limited to the glands, and the patient is highly motivated to preserve the organ interstitial brachytherapy, is the most elegant, dosimetrically superior option.
But explain the physics behind why brachytherapy is superior here. Why insert radioactive needles instead of just using the external beam setup we just designed?
It all comes down to the inverse square law and the physical limits of dose gradients. With external beam, the radiation passes completely through the patient, delivering an exit dose to the contralateral skin and the deeper erectile tissues.
So you're irradiating healthy tissue on the way out.
Exactly. But with interstitial brachytherapy, we are surgically implanting hollow catheters directly through the tumor volume and loading them with a radioactive isotope, such as iridium-192. The inverse square law dictates that the radiation dose drops off exponentially the further you move away from the radioactive source. This physical property allows us to deliver an ablative, massive dose directly to the SCC of the glands, while the dose plummets so rapidly that the deeper corpora cavernosa and the proximal healthy skin receive a fraction of that exposure.
That's incredible.
Yeah, you're maximizing local control while physically sparing the deep architecture required for sexual function.
But we need to define organ preservation, honestly, for the listener and for the patient. Because we hear organ preservation and we think it's a free pass, right? A patient hears it and pictures an intact, perfectly functioning penis with zero downside. If I'm counseling case 1, is it a free pass?
It is absolutely not a free pass. The trade-off is stark, and informed consent is paramount.
So what are the numbers?
With modern low-dose rate, or LDR, brachytherapy, or even fractionated high-dose rate approaches, local control for carefully selected T1 and T2 lesions is robust, generally between 70 and 90%.
Which sounds great.
It does, but if we look at the surgical literature, a partial penectomy offers slightly superior local control. The surgical margin is definitive.
So the patient is actively accepting a roughly 10 to 30% risk of local recurrence just to keep the organ.
Exactly. The critical safety net here is that if they fail locally after radiation, the tissue is usually still amenable to a salvage, partial, or total penectomy. A radiation failure does not immediately sentence them to incurable systemic disease, but it does mean they undergo a much more heavily irradiated, morbid salvage surgery later.
Which is a heavy burden to place on a patient. And we must talk about the definitive dosing, too. If a patient refuses brachytherapy and you must use definitive external beam radiation, the prescription must be high. You are aiming for greater than 60 gray, usually pushing to 65 or 70 gray, to the primary tumor volume, calculated as EQD2.
Right, the equivalent dose in 2 gray fractions.
Yeah. And if you are electively treating the nodal basins, those get the standard microscopic dose of 45 to 50.4 gray.
And just to close the loop on brachytherapy, for LDR brachytherapy, the reference prescription is often 55 to 60 gray, but due to the heterogeneity of the implant, the dose immediately adjacent to the needles is substantially higher.
Right.
The medical physicist has to meticulously constrain the dose to the urethral mucosa. Otherwise, you induce strictures or catastrophic soft tissue necrosis.
That makes sense. Let's follow the biology, though, because we've meticulously treated the primary tumor in case 1. The brachytherapy implant was flawless. But we cannot forget his staging, CT2 and 0. It is dangerously easy to cure the primary site and completely neglect the microscopic disease silently amplifying in the femoral triangle. Radiation to the glands does absolutely nothing to address the nodal risk.
The management of the clinically node-negative groin is, one of the most critical decision trees in penile cancer.
It really is.
For a T2 lesion, the risk of occult microscopic metastasis in those clinically negative inguinal nodes is high enough that observation is considered oncologic negligence. The standard of care framework mandates early surgical nodal staging.
We are talking about either a dynamic sentinel node biopsy, the DSNB, or a modified inguinal lymph node dissection, the ILND. But I want to emphasize why we need surgery here. Why not just get a PET CT and look for hypermetabolic nodes?
Because the spatial resolution of a PET CT is roughly 4 to 5 millimeters. If a patient has a 2-millimeter cluster of aggressive squamous cell carcinoma cells sitting inside a superficial inguinal node, the PET CT will be stone-cold negative.
Completely silent.
Exactly. Clinical exams are similarly insensitive. You need pathological tissue. In a DSNB, the surgeon injects a radiotracer, usually technetium-99 meter, along with a blue dye into the primary tumor site, tracks the lymphatic flow to the very first relay node in the groin, and excises it.
Right.
If it is negative, the groin is spared. If it is positive, or if a formal ILND reveals positive nodes, we enter the domain of adjuvant radiation. And this is where the InPACT framework fundamentally changed our practice.
Because before InPACT, there was virtually no international consensus on exactly which vessels to contour, where to draw the borders, and how to define the inguinal and pelvic basins for penile cancer. Planners were guessing based on anal cancer or vulvar cancer atlases, which have totally different lymphatic drainage patterns. InPACT provided a massive win, a standardized, peer-reviewed contouring atlas. But there is one anatomical structure in that atlas that catches planners off guard constantly. It is the geographic miss waiting to happen.
Oh, the prepubic fat. You were referring to the prepubic fat space.
Yeah, exactly.
Let me explain the exact mechanism of this error. A resident will sit at the planning station, Pull up the CT scan and correctly identify the right superficial and deep inguinal nodes clustered around the right femoral vessels.
Right.
They contour that. Then they do the exact same thing on the left femoral vessels.
And it looks perfectly fine on the screen.
Right. The result is two separate, distinct target volumes on the right and left, with a large, seemingly empty gap of subcutaneous fat sitting directly in the midline, anterior to the pubic symphysis.
But the lymphatic channels originating from the base of the penis literally traverse that prepubic fat to reach the groins. The channels don't magically teleport. If you leave a midline gap between the right and left inguinal volumes, perhaps thinking you're being clever and sparing the midline skin to reduce toxicity, you are leaving microscopic disease untreated.
It's a huge mistake.
That cancer will continue to track through the prepubic space, and the patient will present a year later with an unsalvageable fungating recurrence erupting right above the pubis. You must connect the bilateral inguinal volumes across the midline, include the prepubic fat.
That is such a critical contouring pearl. So once we have the inguinal contouring mastered, we face the next highly testable, high-stakes clinical question.
And we treat the pelvis.
Exactly. If the surgeon removes those nodes, what specific pathological findings force us to cross the inguinal ligament and deliberately irradiate the deep pelvic lymph nodes?
Right, because if a patient has just one positive groin node, my instinct as a planner is to chase the microscopic spread into the pelvis just to be safe. We know it spreads sequentially. Why is the modern, board-defensible logic telling us to hold back?
We hold back because comprehensive pelvic radiation carries severe, lifelong risks. Lower extremity lymphedema, bowel toxicity, bladder fibrosis. We need pathological proof that the risk of pelvic involvement justifies that toxicity.
So what's the threshold?
The modern consensus gives us a very clear numerical threshold. If the pathology shows 1 to 2 positive inguinal nodes and there is absolutely zero extranodal extension, or ECE, the probability that the cancer has breached the deep pelvic nodes is statistically quite low. In that scenario, you can safely limit your radiation fields strictly to the bilateral groins.
But the moment the pathology report crosses a specific line, the entire calculus shifts. The trigger for high pelvic risk is 3 or more positive inguinal nodes, or the presence of any extranodal extension.
Right, any ECE at all.
Extranodal extension means the tumor was so aggressive it literally chewed its way through the capsule of the lymph node and is spilling into the surrounding adipose tissue. If you see ECE, or if there are 3 or more nodes involved, the dam has broken. You must extend your clinical target volume to include the external iliac, internal iliac, and obturator pelvic nodes.
So 1 to 2 nodes without ECE equals low pelvic risk. 3 or more nodes, or any ECE, equals high pelvic risk requiring comprehensive pelvic fields. Now, while we are engineering the physical delivery of these groin fields, we have to highlight a severe dosimetric trap associated with modern linear accelerators.
This is the VMAT trap.
Yes, VMAT.
Volumetric modulated arc therapy, or VMAT, and intensity modulated radiation therapy, IMRT, are miracles of modern physics. The gantry rotates 360 degrees around the patient, while the multi-leaf collimator leaves slide back and forth, painting the dose perfectly to conform to deep, complex shapes like a prostate or a pelvic tumor.
They are amazing tools.
But the algorithm that drives VMAT is heavily kinalized if it delivers high doses to the skin. It wants to spare the skin at all costs.
And that is a massive problem when your entire oncologic target sits literally millimeters beneath the skin.
Because the inguinal nodes are superficial.
Exactly. The superficial inguinal nodes are housed in the subcutaneous fat of the femoral triangle. Because we are using high-energy megavoltage photons, there is an inherent physical buildup region before the dose reaches its maximum penetration, as we discussed earlier.
Right.
If you allow the computerized optimizer to run without strict manual oversight, it will utilize multiple beam angles to push the dose deep, inadvertently leaving the most anterior, superficial portions of your target volume severely underdosed. Your dose volume histogram might look acceptable on average, but if you look at the axial CT slices, the skin and the first centimeter of tissue will be cold.
So what is the dosimetric solution? You have to physically interrogate the plan. You cannot just accept the coverage statistics. Scroll through the axial CT images. Evaluate the anterior border of your planning target volume, the PTV. Look at the isodose lines explicitly near the skin surface.
You have to look closely.
If the 95% isobose line is failing to cover the superficial nodes, you have to manually intervene. You must explicitly decide to place physical bolus over the groins during treatment to force the dose buildup to occur outside the patient's body, bringing the therapeutic dose exactly to the skin surface where the superficial nodes reside. Never let a computerized optimizer trick you into a marginal miss.
Such good advice. We've spent a significant amount of time detailing the external anatomy and nodal complexities of Case 1. Let us pivot to the profoundly constrained internal anatomy of Case 2.
The female distal urethral SCC.
Yes, we have a 58-year-old woman presenting with a distal urethral SCC. The clinical staging is T2. The MRI shows the tumor invading the periurethral muscle, but the vaginal wall is entirely spared. She sits across from you in the consultation room, and like Case 1, her primary goal is organ preservation.
Which is totally understandable, because for a female patient facing a distal urethral cancer, the standard surgical intervention is an interior exenteration, removing the urethra, the bladder, and the anterior vaginal wall and creating a permanent urinary stoma.
It's a massive surgery.
So when we discuss radiation as an organ-preserving alternative, we are offering interstitial brachytherapy. Specifically, we often use a Syed-style template, which is a perineal template that guides a dense array of rigid needles through the perineum, surrounding the urethra and the vaginal cylinder.
Right.
It can be used as monotherapy or combined with a moderate dose of external beam radiation. It avoids the stoma, but we must discuss the grueling reality of the toxicity.
We really do. The counseling here cannot be sugar-coated. When a patient hears organ preservation, they visualize a return to normal urinary and sexual function. We have to definitively dismantle that expectation. A Syed template implant delivers a massive ablative dose of radiation directly to a highly compact anatomical corridor.
Everything gets hit.
The distal urethra, the bladder neck, and the anterior vaginal wall are bathed in radiation.
Let's break down the pathophysiology of why the toxicity is so severe. Radiation obliterates the microvasculature. You get endarteritis obliterans, the small vessels feeding the urethral mucosa swell and scar shut.
Exactly.
The tissue becomes profoundly hypoxic, hypocellular, and hypovascular. Over months and years, the normally pliable periurethral muscle turns into a rigid fibrotic pipe. The immediate clinical consequence is severe urethral stenosis. The patient will likely require painful, repeated mechanical dilations just to empty her bladder.
Stenosis is the most common consequence, but the most devastating complication is tissue breakdown. Because the anterior vaginal wall and the posterior urethra share a microscopic fascial plane, that intense hypovascularity can cause the tissue to simply give way, resulting in a urethrovaginal or vesicovaginal fistula.
Oh, fistula there is it's a nightmare.
A fistula in a heavily irradiated field is a surgical nightmare. The tissue has no blood supply to heal a primary repair, meaning the urologist often has to harvest a muscle flap from the leg or abdomen just to plug the defect. Organ preservation with a Syed template does not equate to low toxicity.
That's the key takeaway.
It simply means trading the immediate permanence of a surgical stoma for the chronic, unpredictable, and potentially severe morbidity of high-dose pelvic radiation. The patient must understand they are choosing a very difficult path.
While we are discussing urethral pathology, we need to touch on the counterpart scenario. We don't have a specific case for this, but locally advanced male urethral SCC is a highly testable concept. Imagine a male patient with a bulky T3 tumor originating in the bulbar urethra, extending deeply into the perineum. Primary surgical resection for a tumor that advanced involves a massive, functionally destructive tissue defect.
In that locally advanced male scenario, the paradigm shifts entirely away from primary surgery. The standard of care approach becomes definitive chemoradiation, heavily mirroring the treatment paradigms we use for anal cancer.
Oh, like the Negro protocol approach.
Exactly. We use concurrent chemotherapy to radiosensitize the tumor while delivering definitive doses of external beam radiation.
But the clinical data for chemoradiation in locally advanced male urethral SCC is fascinating, but ultimately sobering. The initial response rates are stellar. Nearly 79% of these men will achieve a complete clinical response. The tumor essentially melts away on the post-treatment imaging.
But the durability of that response is the true challenge. Despite that impressive initial complete response, roughly 42% of those patients will eventually experience a local relapse.
Almost half.
Yes. The cancer stem cells survive the radiation and eventually repopulate. The counseling tone must bridge that gap. We have an excellent probability of eradicating the visible tumor initially, but there is a near coin flip probability that the disease will recur, at which point salvage surgery becomes the only albeit highly morbid option.
And there is a critical histological caveat that you must screen for before you sign the chemotherapy orders. We have been discussing squamous cell carcinoma, which relies on regimens often utilizing 5-FU and mitomycin. But what if the pathologist looks under the microscope and the biopsy from the urethra shows urothelial carcinoma?
Ah, that is such an important distinction. If the histology is urothelial carcinoma, which is common in the prostatic and proximal urethra, your entire systemic therapy logic must pivot. Urothelial histology dictates that we abandon the anal cancer SCC paradigm and adopt bladder cancer principles.
So no 5-FU.
Right. This usually mandates cisplatin-based chemotherapy regimens. The histology strictly dictates the systemic biology, and missing that distinction is a fatal clinical error.
Whether you were treating a penile SCC, a female distal urethra, or a male bulbar urethra, the unavoidable common denominator that will define your relationship with these patients for the rest of their lives is the late toxicity profile. The acute effects, the brisk dermatitis, the severe dysuria, the skin peeling, they are dramatic, but they are transient. We can manage them with aggressive skincare, pain control, and catheterization.
The lead effects, however, are the permanent anchor. As we discussed with the female urethral case, the pathophysiology of radiation fibrosis is relentless. The central, unavoidable, long-term issue in all of these anatomies is urethral narrowing and stricture formation.
Right.
The microvascular ischemia slowly replaces elastic muscle with rigid collagen.
Which means your post-treatment surveillance strategy must be incredibly rigid. When these patients sit in your clinic 6 months, 2 years, or 5 years post-radiation, you cannot just do a quick skin check and discharge them. You must conduct a rigorous, detailed review of their urinary mechanics.
You have to ask the specific questions.
Are they straining to void? Is the urinary stream splitting or spraying? Has the physical caliber of the stream decreased? If they endorse any of these symptoms, your threshold for action must be 0. You immediately refer them back to urology for a cystoscopy to physically visualize the urethra, evaluate for a stricture, and rule out a mucosal recurrence. You cannot manage the survivorship of these patients in a silo. It requires a lifelong, tight, multidisciplinary partnership with urology.
So well said. We have covered an immense amount of anatomical and physical ground today. Let us synthesize this directly into clinical decision-making. It is time for the board blitz. I want you to fire the high-yield scenarios at me, testing the mechanisms we just explored.
Let's do it. Board blitz. Rapid fire. Question 1. You are consulting a 48-year-old man. He presents with a 3-centimeter SCC confined entirely to the glans. He is clinically staged as CT2N0. He underwent a prophylactic circumcision 3 months ago and is fully healed. He states unequivocally that he wants to avoid surgery and requests organ preservation. Based on the established data, what is your standard of care recommendation?
The optimal answer is interstitial penile brachytherapy delivered at a highly experienced center.
And why is that?
Let's look at the criteria. The lesion is under 4 centimeters. It is strictly limited to the glands. He is clinically node negative, and he is highly motivated to preserve the organ. He is the textbook candidate. Now, if a multiple choice option attempts to trick you with external beam radiation to 50 gray without bolus, you must immediately recognize the dosimetric failures.
There are 2 big ones there.
Right. First, 50 gray is biologically inadequate for definitive control of gross SCC. You need upward of 65 gray. Second, without bolus, the Dmax will fall deep to the skin, severely underdosing the superficial tumor. It must be high-dose brachytherapy or definitive external beam to 65 to 70 gray with perfectly executed surface bolus.
Spot on. Okay, question 2. A 62-year-old man presents with a bulky, locally advanced bulbar urethral SCC. The MRI shows the tumor originating in the bulbar urethra but extending anteriorly, infiltrating the distal penile urethra. The tumor board recommends definitive chemoradiation. As the radiation oncologist, which specific nodal basins are you legally required to cover in your target volume?
This question is a direct test of the DGP rule, but with the anatomical watershed twist we discussed.
The bulbar region.
Yes. The bulbar urethra represents the transition zone between the distal and proximal networks. Because this tumor is locally advanced and physically extending into the distal penile urethra, it is simultaneously engaging both the anterior, superficial lymphatic network and the posterior deep lymphatic networks.
So you have to cover everything.
Therefore, the target volume must comprehensively include both the deep pelvic nodes and the bilateral inguinal basins. You cannot pick one. You must cover the full bidirectional drainage pathway.
Excellent. Okay, final question. A 55-year-old man recently underwent a partial penectomy and a bilateral inguinal lymph node dissection for a high-risk primary tumor. The surgical pathology report reveals 3 positive right inguinal lymph nodes, and one of those nodes demonstrates frank extranodal extension, the ECE. He also has 1 positive left inguinal node. The urologic surgeon notes that a gross total resection was achieved and all surgical margins are negative. What is your precise adjuvant radiation recommendation regarding volumes and dose?
This scenario triggers several critical thresholds. He has 3 positive nodes on the right, and he has ECE.
Both are bad.
Right. Based on the modern contouring logic, the presence of either of those factors automatically categorizes him as high risk for microscopic pelvic involvement. Therefore, the required target volume is adjuvant bilateral groin radiation, seamlessly connected to comprehensive pelvic radiation.
But what about the dose?
The dosimetric trick here is restraint. The surgeon achieved a gross total resection. There is no measurable tumor left behind. You are strictly treating microscopic subclinical disease. Do not blindly prescribe an ablative dose of 70 gray. Shooting for the moon with the dose when there is no gross target will only guarantee severe permanent lymphedema. The correct adjuvant dose for microscopic disease is in the 45 to 50.4 gray range.
You correctly navigated the high-dose trap and respected the 3-node and ECE threshold. And we take a step back from the specific fractions in the pathology reports and look at the totality of what we have unpacked today. How would you summarize the overarching philosophy of managing these incredibly rare, complex GU malignancies?
The philosophy hinges on 3 non-negotiable principles: profound anatomical respect, obsessive reproducibility, and clinical restraint. You cannot plan what you do not understand anatomically. You must intimately know the microanatomy of the tunica albuginea, and you must trust the DDP nodal pathways distal to the groin, proximal to the pelvis.
And reproducibility.
Second, your daily physical setup must be perfectly reproducible because the dose gradients in brachytherapy and surface bolus are completely unforgiving of a millimeter shift. And finally, restraint. Just because we physically possess the technology to radiate these organs does not mean radiation is a consequence-free alternative. You must counsel patients with brutal honesty about the real permanent risks of microvascular ischemia, urethral stenosis, and catastrophic fistulas.
Precision in delivery and honesty in counseling. And that leads me to a final, slightly provocative thought for everyone to mull over during their drive home. Today, we spent so much time discussing the massive, wide-field radiation required to chase microscopic disease, connecting the bilateral groins across the prepubic fat, radiating the entire deep pelvis because a pathologist found extranodal extension in a single superficial node.
We threw a very wide net.
We do. But as we look at the breathtaking advances in targeted therapies and immune checkpoint inhibitors revolutionizing other squamous cell carcinomas like head and neck or cutaneous cancers, how long until those systemic drugs become potent enough to alter our local targets?
It's a great question.
Will we eventually reach a point where these ultra-rare GU cancers can be managed with vastly shrunken, highly targeted radiation fields? Or will the inherently unpredictable, stepwise biological migration of cancer cells through these specific lymphatic pathways always force us to cast a wide, highly morbid net, regardless of how good the systemic drugs become?
That is the ultimate tension in modern oncology right there. Systemic biological control versus the sheer architectural complexity of local invasion. I suspect the complex embryological anatomy of the urogenital tract will always demand deep physical respect, but the aggressive nodal doses we prescribe today might eventually evolve. It is exactly the paradigm shift we will be tracking closely over the next decade.
I couldn't agree more. Complete practice oral boards at radongsmartlearn.com and subscribe to Radong's Smart Review for our next episode. Thanks for tuning in.